Acute rheumatic fever is a multi-system disease that occurs in people previously affected with streptococcal, that is group A, sore throat, and it is an autoimmune reaction. Although most of the symptoms of the acute rheumatic fever resolves completely, except cardiac valvular damage, therefore it is called rheumatic heart disease also. The organism that causes is group A Streptococcus pyogenes, and the most commonly affected group of humans is the children of the age 5 to 14 years. Rheumatic heart disease have more chance in the females. One of the major diagnosing factor for the rheumatic heart disease, acute rheumatic fever, is that it occurs following upper respiratory tract which have occurred 3 weeks back. It is explained, the pathogenesis of the acute rheumatic fever is explained through the autoimmune theory or the molecular mimicry theory. The Streptococcus pyogenes contain a highly virulent antigen called the M protein. So antibodies are produced by the body against this M protein. Similar, the M protein like proteins are present in the bones and the heart. Therefore, the cross reaction between these antibodies with the tissue antigens causes rheumatic heart disease. The clinical manifestations occur mainly in the heart, joints, skin, and the brain. In bones, one of the major clinical features is the migrating polyarthritis. That is, joints become hot and swollen, red and tender, which moves from one joint to another. Commonly affected joints are knee joint, ankle joint, and the hip joint. Pancardiitis is another feature. The endocardium, the myocardium, and the pericardium is both the three layers of the myocardium is cardiac muscle is involved. Subcutaneous nodules, small mobile nodules, lumps are found against the bony prominences. Another feature is the Sydenham scoria, slight tremor. The erythema marginatum is another feature. These are pink macular rashes which appear and disappear before the examiner's eye. The diagnostic criteria for acute rheumatic fever is the modified Jones criteria, modified in the 2015. Earlier, anti-streptolysin O titer was also part of the Jones criteria, but now it is not. The Jones criteria consists of major criteria and the minor criteria. The diagnostic criteria for the acute rheumatic fever is 2 major criteria or 1 major plus 2 minor criteria. If there is recurrent acute rheumatic fever rather than initial acute rheumatic fever, 2 major criteria or 1 major criteria plus 2 or 3 minor criteria are the factor. So what are the major criteria? In the low risk populations, the major criteria is same as that of the clinical symptoms. That is the carditis, arthritis, that is mainly the polyarthritis. Migrating polyarthritis is one of the clinical feature. Then chorea, then subcutaneous nodules and erythema marginatum. In high risk populations, the arthritis, it can be considered both monoarthritis and the polyarthritis, and polyarthralgia case also. So what's the difference between polyarthritis and polyarthralgia? The polyarthralgia, there is only pain and no inflammation. Polyarthritis, there is inflammation also. The minor criteria are polyarthralgia in the case of low risk populations, hyperpyrexia, and ESR value more than that of 60 millimeter per hour, and prolonged PR interval. Prolonged PR interval is one of the major ESG findings found in the acute rheumatic fever. And the moderate and high risk populations, monoarthralgia along with hyperpyrexia, and ESR more than or equal to 30 millimeter per hour, and CRP also more than 3 milligram per deciliter, and also prolonged PR interval. How will you prevent the recurrence of such episodes of acute rheumatic fever? So the major treatment, as we all know, the major treatment of the acute rheumatic fever is penicillin, as the streptococcal infections are usually treated by penicillin, and penicillin is a drug of choice for streptococcal infections. And the prevention of this infection can be through two mechanisms, that's the primary prevention and secondary prevention. Primary prevention includes the complete and timely intervention for the treatment of the group A streptococcal sore throats by the antibiotics, especially the penicillin. And secondary treatment involves long-term prophylaxis, penicillin prophylaxis by using benzathine penicillin. If they are penicillin allergic, then erythromycin can also be used. The 3 points that should be noted is that in persons, people with acute rheumatic fever without carditis, the prophylaxis continued for 5 years after the last attack and 21 years of age. If acute rheumatic fever occurs with carditis but no residual valvular disease, then it can be continued for 10 years after a last attack or 21 years of age, whichever is longer. Or if acute rheumatic fever is present with persistent valvular disease, then 10 years can also be it can be continued after the first attack, last attack, and 40 years of age.